we can get everybody to pull through on the discussion and make it a peer-to-peer learning. So today we are going to be talking about fluid therapy in small animal disease. You will agree today is 23rd February 2023, just 2 days to the election, and we will try and make this a little bit very snappy. So please to the next slide, Bola. Next slide, Bola. So you just follow me since you're controlling the slide so that we can be on the same page.
Okay, so I'll move to the next slide shortly.
Okay, all right, good. So while she's moving to the next slide, I think I will just proceed with the beginning part of the introduction. So we have a few partners in Tecla. Tecla is tele-education series for clinicians and leaders in Africa. Our partners are MDoc. We have Boringa Ingleham, which is one of the foremost animal health company we have in Nigeria, in the world, rather. Boringa and Asuka came together to Making More Health. I'm proud to say that Farmalat is a Making More Health fellow. Now, our agenda for today, I'm going to be running us through a brief agenda for today. The first we'll have in our agenda, we will have a brief introduction by Dr. Tumsia. So I'm just holding brief for her pending when her network gets slightly better. Then we'll have a brief about Farmalat, which will be taken by Dr. Esther. Then also a brief about Tecla. Then we'll go into the pre-quiz by all participants, just very simple questions that everybody needs to answer. And the nice thing about the pre-quiz is that it's being answered and like it's anonymous. So you can feel free and just freestyle and exercise exactly what you think the correct answers are. And at the end of the day, our hub experts will be answering those questions. We also will be having the didactic presentation by our very own Professor Ajadi, who will be taking us on a brief didactic session, giving us a background of fluid therapy, what we need to know. Then, of course, we'll be inviting Dr. Tessie, popularly known as Dr. Tessie, Dr. Teresa, to come give us some practical view on what Professor Ajadi has presented and also lend a voice to the discussion. Then we will have a very young vet who will also be presenting a case on fluid therapy. After that, we will enter into a 40-minute participatory session where we'll be dissecting the basis of the case presentation and we'll be answering questions. And our hub experts will be providing us expert opinions. We will also have the liberty of calling people because I can see some also very important people also on the call. So we'll be calling for expert opinions. At the end of the day, we give our expert recommendations from our hub experts. We'll do our post quiz. And at the end of the day, Dr. Tumsia will be giving the announcement and possible next step. Let me just give a brief overview of our ECHO model. It's operated on 4 pillars. We're using video conferencing technology to leverage scarce healthcare resources. We usually say we are moving knowledge instead of moving people. It's expensive now to move people. So we are leveraging on using the telecommunication, tele-education technology that we have, using the Zoom platform to see how we can all gather together. You agree with me that people who attend our Tecla sessions are coming from various parts of the country, proudly also to say various parts of the continent, and if you would like me to say various parts of the world. So we are using one single platform to move knowledge across board. We specialize sharing best practices with colleagues. Everybody on the call is ideally supposed to be a veterinarian or an animal health professional. We also use case-based knowledge learning. That is why we are also calling Dr. Abiodun to give us a case that we are going to be dissecting. And of course, we use continuous monitoring of this program to better the outcome for subsequent sessions. Please take note that these sessions are recorded, but your data will be kept privately. Some of the tips that we will have before we move into the bulk part of the day is that please ensure we have disabled your ability to unmute yourself just to keep a little decorum. But we also like that your cameras are on so that we can keep a view of who is paying attention and who is not. If you're in a convenient place, but if you're wearing something not appropriate, sometimes we see some people put on their cameras and they are wearing singlet. We, by that, ask you that you should turn off your camera if you're not dressing appropriately. But if you are, why not please be our guest? Our facilitator, who is going to be Dr. Tumsia, will unmute anyone when it is time to speak. And then you can also use two functions on the Zoom. You can use your raise hand button to alert us if you want, or if you have any comments to make based on what we're presenting. Or better still, you can use the chat bot. The chat bot is almost always available, and we have people dedicated, Dr. Bolanle, at the background, dedicated, looking out for whatever comment it is that we need to pay attention to. And we also advise that you should please help us keep your comments respectful. We are in a community of professionals, and we believe that respect is something that needs to be used so that we can keep the decorum of the presentation. Right now, we are going to be inviting Dr. Esther. I hear she's the one giving us a brief about Farmalab. If Dr. Esther is on ground, you can please come up. All right, so I see you. So give us 2 minutes brief about Farmalab, what Farmalab does and what Farmalab represents. Over to you, Dr. Esther. Dr. Esther is a graduate of University of Ibadan, a DVM graduate of University of Ibadan, also working with Farmalab and serving as one of our resident doctors in Lagos. Over to you, Dr. Esther. Dr. Esther, you're muted, so can you please unmute yourself and start all over again? All right, so
can you hear me now?
Yes, fantastic.
Right. Okay, hi everyone. Thank you, sir. Thank you for the introduction. As introduced, I'm Dr. Esther Olorunfemi, a resident veterinarian at Farmalab, and I'll be giving us a quick brief about Farmalab. So Farmalab is an animal health social enterprise, was founded in 2019 with the primary mission of enabling easy access to affordable animal health care in underserved communities in Africa. Animal diseases, as we know, are the major cause of losses, the major factor of losses in pet ownership and in livestock farming. It accounts for over 70% of the total damage caused, according to statistics, and that is on the eye side. Unfortunately, the animal health system in Africa is not too good, and that goes a long way to affect pet owners and these livestock farmers who are the lifeline of our local food system. So at Farmalab, we've been able to combine our relevance as a major animal healthcare brand in the marketplace with our mission of ensuring that animal health products are easily available, they are accessible and affordable. We partner with local animal health professionals, mainly veterinarians, who partner with these pet owners and local farmers to build an inclusive system of sustainable animal health and disease prevention. We also foster peer-to-peer network, a peer-to-peer network where you can easily access regular animal health products and veterinary services and pieces of training here and there to ensure that everybody has enough knowledge and enough insights to ensuring that this sustainable animal health system is built. So in summary, we are enabling easy access to affordable animal health care across the nation and soon across Africa. So this is a Tecla session, and just like Dr. has said earlier, our Tecla sessions are in partnership between the largest privately held animal health company in the world, Boehringer Ingelheim and Ashoka. Ashoka is a company that is dedicated towards supporting social entrepreneurs. And our education partners are MDoc. So we do all of these things with them, and we use technologies like this video conferencing app that we're using at the moment, Zoom, to ensure that we reach as many people as possible so that distance is no barrier. So it's our uttermost desire that you enjoy this session and that you get all that you can from it. Once again, I welcome you to our ever-growing community. Please enjoy this session. Thank you very much.
All right, all the best. Thank you so much, Dr. Esther, for the warm brief about Parmalat. Just a moment, and thank you for doing a very good job with the introduction. So I'm just going to be coming in to state a brief about Tecla. So Tecla, as I said initially, is tele-education for clinicians and leaders in Africa. And one of the key things that Tecla aims to achieve, as I said earlier in our introduction, is to move knowledge, not necessarily people. It's becoming very expensive to move people. It's easier now to move knowledge using technology such as this. And our execution partner is MDoc, who has handheld Parmalat to see that we can get to this stage. So having said that much, let's start moving into what we have today. So, but before we invite our hub expert, Professor Ajadi, okay, maybe we should quickly just do our polls. The polls are anonymous. We are just going to be testing knowledge and testing knowledge. All you just need to do is just to attempt what you think is the answer. At the end of the day, we expect that everybody should have learned and be able to answer it 100%. But if you cannot right now, it's not a problem. All we want is that you make an attempt. So I'll be launching the pre-quiz now, and then you will have 3 minutes to get it through. Can we all see the pre-quiz? If you can see the pre-quiz, can you just help me say something at the chat box that I can see the pre-quiz? Can we all see the pre-quiz? Just help me. Oh, fantastic. So let's get going. We have 3 minutes to go over the pre-quiz. There are 10 questions. Oh, fantastic. Thank you, Dr. Adamu. You can see the pre-quiz. There are 10 questions. You are expected to answer them, and then we get going. No one is going to be scoring you. We just want to have a good background of what you know prior to the lecture and the interaction. And at the end of the day, we take a sensor of the knowledge gain based on what you must have learned from the interaction. So please feel free to answer the questions. There are 10 questions, and we'll have like 3 minutes. We're going to be stopping the pre-quiz once we have like 50% participation. Some people are saying they cannot see the pre-quiz, but can you all see the pre-quiz? Oh, some people have started answering. So I'm wondering why you cannot see the pre-quiz. Okay, if you can see the pre-quiz, can you just say something on the chat board? But some people have started answering the pre-quiz question. It's nice to see everyone. We are over 120 participants now. We're expecting a slightly full house. We had over 400 people registered. So we're expecting the participation of this Tecla session to be, live participation to be a little bit over 200. Mostly small animal practitioner. Thank you so much. Somebody said she has submitted her responses. Thank you. And I happen to know the person who has said that. I presume she will have 10 over 10. And we feel very humbled to have our lecturers join meetings like this. Feels very, very humbling. Thank you for participating. Thank you for joining. And we are going to make, of course, the conversation a little bit very robust. so that the quality of experts that we have could have a say in the whole knowledge body that we're trying to promote. So 12% participants have submitted their responses. We're going to shut it down once we have 50%. So please just keep attempting. I can see from my dashboard various answers, and interesting that at the end of the day, we'll come together and all answer the question the best way we can under the direction of the hub expert. So we have 23% participation who have submitted their responses. We want to push this down up to 50%, then we can stop. All right, thank you, Dr. Desai. I can see you said done. We have 31% responses submitted. It means that 42 people have submitted their responses. The room is made up of over 130 participation. So once we get up to 70% people submit their responses, then we can call it a day for the pre-quiz and go. Thank you, Dr. Chioma Obwa. You said you're done. Thank you. We have 40% submitted their responses. We just have, thank you, Dr. Awuyele John. He said done. I can see we have 42% who have submitted their responses. We're going to move it to a little bit over 50%. Thank you, Dr. Okafor Linda, for finishing. Thank you, Dr. Karim Adetula. Thank you, Dr. Chukwebuka Ezefule. Thank you. We have 52%. So let's maybe push it up to 60%, or perhaps 70. Thank you, Dr. Amaka. She said she's done. Thank you, Dr. Anas Musa. Thank you. We have 55%, 71 people have submitted their responses. Thank you, Dr. Anas Musa. Let's push this a little bit further. Done, Dr. Easy Jafet. Thank you, Nuhu, for submitting your response. We have 57% people who have submitted response. 75 people have actually. Dr. Chinyere, thank you. Dr. Saidu Yakubu, thank you. Dr. Manasseh, thank you. Dr. Tolulope Akin Fawale, thank you. 59% have submitted. Thank you, 77 participants out of 130 have submitted their responses. We have 78. Thank you, Dr. Ugochukwu, thank you. So we have 60%. I'm just going to count down to 60, and then we will end the pre-quiz. Dr. James, thank you. So we have just 60 seconds to go. Then we'll be done. I want to heartily thank everybody who has participated in the pre-quiz. Over 80% have submitted, and I can see a lot of different answers. So that's the reason for the class, to ensure that we all leave after an hour of interaction, better people, better clinician, and 61, 62%. So we have less than 30 seconds to bring it down. Hurry. If you're on number 5, number 6, hurry and get it through. We have less than 20 seconds to bring down the poll. Yep, so we have 15, we have 14, we have 13, we have 12. Okay, all right, so the poll is up. Thank you so much, everyone, for filling in your responses. At the end of the day, we're going to be taking the post quiz, and you will be scoring yourself to know if what you have specifically answered is correct. Right now, I want to introduce our hub experts. The pre-quiz is done. The first hub expert, we are going to a well-respected, really well-respected member of the veterinary community. No, the first, that's Professor Ajadi. Professor Ajadi is the head of the department, veterinary surgery and genealogy Federal University of Agriculture, Abeokuta. You know, while we were putting together this, we called Dr. Abiadi, who is a private practitioner, and we said, who will you want to listen to talking about fluid therapy? And the first name that came to his mind is Professor Ajadi. Thank you so much, Professor Ajadi Adetola Rashid, for gracing this meeting. And we're going to be listening to you shortly for another 15 minutes. So next slide. The next person, it's a veteran in the private industry. Some of us, we usually say that when we grow up, what you want to be is to be successful as people like Dr. Tessie. Dr. Tessie's name is more popular than Dr. Teresa, but of course, she owns a vibrant and an elaborate veterinary hospital in Ibadan. She's into the production of some of this pet food, and one of the brilliant clinicians that we have, and we are almost always proud of in the veterinary industry. She's going to be bringing in some perspective, maybe probably billing. I'm also interested in how she builds to be that successful in Ibadan. So welcome everyone, Dr. Mrs. Teresa, as she joins our hub expert list. The next person will be our case presenter, another vibrant UI product who was also in our community some few months back and won our grant, 250,000 grant. And he has been doing amazing work with the ultrasound. Is it ultrasound? I can't remember exactly what he bought. Vibrant on social media, but more importantly, vibrant in going out there to attend to cases. He's going to be our case presenter and will be presenting a peculiar case for around 5 minutes. Then we'll open up the discussion to the general participant. So, ladies and gentlemen, I think, dear colleagues, it now gives me a very good pleasure to invite Professor Ajadi. I need to be sure that his network is good. Okay, so his co-host, I need to spotlight him. Welcome, sir. I'm good to have you, Prof.
Thank you, sir.
All right, so who is sharing his presentation? Dr. Bola, is he going to be sharing his presentation or you'll be sharing his presentation?
I'll be doing it from here.
All right, fantastic. Prof, you have the next 15 minutes to tell us everything we need to know.
15 or 25 minutes?
All right, so we want to say 15 minutes, but we can give you an extra grace of 5 minutes so that we can leave more room for discussion.
Hello, is it 15 or 25 minutes?
So, sir, so let's stay at the middle, 20 minutes, sir.
Okay, the message that was sent to me actually to prepare a lecture for 25 minutes.
Right,
okay, I will do the best. I will see what we can do within the time allotted. Thank you very much, the host. I'd like to thank the other hub experts as well as the participant. Well, I've been introduced. My name is Ajadi Adetola Rashid, and I'm a professor of veterinary surgery at the Federal University of Agriculture, Abeokuta. And I will be sharing with us what I title fluid therapy in small animal practice. And why are we looking at this? Fluid is probably the most important thing in the body of the animal. In our discussion today, we're going to be looking at 5 major aspects, the physiology of water. And the reason is because as clinician, you need to understand what is going on in the body of the animal that you're introducing the fluid. We want to know why do we need to administer fluid. We'll be looking at the things that we need if you're going to do a successful fluid therapy, and then what are the choices available to us. And finally, I will look at a few essentials to management of fluid therapy. Thank you. Next slide, please. Okay, now we all know that water is a universal solvent. It is present in every tissue of the body. Now, the water dissolves all the electrolytes and the non-electrolytes that is present in the body. It serves as a medium of transportation for all the electrolytes. I'm talking about organic salts, inorganic salts, acid, bases, proteins, and then the non-electrolytes that are present in the body. Now, this water is not just inside a cup. The water is distributed in different compartments of the body. Generally, the water is divided into two major compartments. The intracellular compartment, that is the water that resides inside of the cell. And then the extracellular compartments, that's the water that is outside of the cell. The extracellular compartment is made up of three compartments. The one that is present inside of the blood vessel, that's what we call the plasma compartment. Then there is one that is present in between the cells, that is the interstitial compartment. And then we have small amount of water present in the lymphatic vessels. Please, can we move on? Okay, you'll notice that the intracellular compartment, the water present in the cells, actually accommodates about 65% of the total body water, while the interstitial compartment occupies almost about 25%. The plasma compartment, or what we call intravascular compartment, occupies 8%, while the one that is present in the lymphatic system occupies the rest. Please, can we move on? Now, the water that is present in the body, they are not just static. They move from one compartment to another. So you see water moving from the intracellular compartment to the interstitial compartment, or water moving from the intravascular compartment to the interstitial compartment. That is what happened. And this movement is governed by three major forces. The first one is what we call the osmotic pressure. The osmotic pressure is the pressure that governs the movement of fluid due to concentration of the electrolytes or the solute that is present between the two levels. You know, generally osmosis is defined as movement of water from a region of lower concentration to a region of higher concentration. So normally water will move when there is a concentration difference between the two compartments. Apart from that, we also have the hydrostatic force. That is what moves water within the intravascular compartment. And then we also have the forces, the pumps, that moves water against gradient. Please, can we move on?
Bola, Dr. Bola, can you please? Don't worry, Prof, we'll account for these small delays.
So what is water balance? Water balance simply means that there is an equilibrium between the water that is taken in by the animal and the water that is excreted by the animal. Whether the animal eats or not, water is lost. Because daily the animal has to urinate, there's defecation, water is lost in form of respiration. And this water that is lost must be restored back. If there is a disequilibrium between water intake and the water that is lost, then there is going to be a problem. And that is why we are looking at fluid therapy. That's the main essence of fluid therapy. Next slide, please. Next slide. Okay, next slide, we'll talk about this. Next slide, I think we have looked at this. We have looked at this, please. Okay, so why do we, next slide, please.
Is it this one with the objectives?
Yes, this one, yes, yes. So why do we perform fluid therapy? There are four major reasons. The first one is to ensure that there is a normal hydration status of the animal. That is water balance. That's the first one. We don't want the animal to go into a deficit. The second reason is to replace any volume that is defective. So if there is a volume deficit or there is a composition deficit, because when we are talking about fluid, fluid is not just about water. Fluid also consists of the electrolytes that is present in the water. And when fluid is lost, sometimes electrolytes are lost. Sometimes also the fluid may not be lost, it's only the electrolyte that is deficient. So when there is a deficiency, either in the volume of the fluid or in the electrolyte, there is also a need to maintain that equilibrium. And that's why we do fluid therapy. The third reason is to maintain essential electrolytes and nutrients. The fourth indication for fluid therapy is to contribute to the maintenance of acid and base balance. Let me quickly say this. The electrolytes, when they dissolve in the body fluid, they either form weak acids or weak bases. And that is what maintains the acid and the base balance of the animal. This acid and base balance is essential because that is what determines the functionality of the enzymes that are present in the system. It determines the homeostasis and the metabolism that is going on within the body system. Next slide, please. Next slide.
On the next slide, we're on
Okay,
indication.
yes, I can see it now. I can see it now. So the indications, one, for surgery. And I use the word the peri-anesthetic support. Now, what do I mean by that? During surgery, you require anesthesia. Most of the drugs, if not all the drugs that is used for anesthesia, affects the cardiovascular system. They depress the cardiovascular system. And the result of this is hypotension. Hypotension can result in death. So in order to maintain the normal vascular function of during and after surgery, then you need to support the animal with. There is. We also need to do fluid therapy when we want to manage dehydration. And the fluid volume is too much. Like I said, it's not just about deficiency. Sometimes also there could be too much fluid. And when there is too much fluid, it affects the cell because where the cell becomes turgid. And if care is not taken, that cell will burst. So that is why it is important also when there is hypovolemia. We're going to see that in cases of, for instance, pulmonary edema, if we over-infuse the animal, that could result in pulmonary edema, and that will result into death. Next slide. So what should be our goal when you are planning your fluid therapy? Please, it's important. Fluid therapy is not something that we do haphazardly. You must have a plan. And what do you want to achieve with the animal that I want to rehydrate or I want to administer fluid therapy? Your first goal is to make sure that you maintain a fluid between the different compartments. You don't want too much fluid in the intracellular compartment at the expense of the interstitial compartment. You don't want too much fluid in the intravascular compartment at the expense of the intracellular compartment. There will be trouble. So the first thing is you want to maintain a balance of fluid between the different compartments. But not only the water, the electrolyte is also important. Because if you just put the water there and the electrolytes are not balanced, the electrolytes are the one that acts as substrate and they determine the movement of water. For instance, if the potassium that is present in the, you remember potassium is the major intracellular cation. If potassium is too much in the cell, what is going to happen is that the cell will try to extrude potassium to the outside, and there will be a problem. So you also want to ensure that you maintain a balance in the electrolyte, as well as maintain. Yeah, thank you. Next slide. So what do you need? First, you need adequate knowledge of fluid disturbance. That is why we are in this class. Without an adequate knowledge of fluid disturbance, you will not be able to achieve it. And one of the things that will give you adequate knowledge of the fluid disturbance is not just enough for you to know that the animal is dehydrated. It is important for you to take sample from the animal and do your electrolytes, do your acid-base status, so that you have an idea. Is there a disturbance in the electrolyte? Which electrolyte is disturbed? Is there a problem in acid-base? Do we have alkalosis or acidosis? You need to have this information if you are going to be able to do appropriate fluid therapy. The next one also is the adequate knowledge of the component of the fluid that you want to use. The fluid I'm using, what does it contain? Replace what I want you and not be able to achieve the goal that you set out. Next slide, please. Next slide. So what do we need? One, adequate information. I mentioned that earlier. Two, you also need adequate, especially in the hospital, because when you want to administer fluid, depending on the route that you are using, somebody have to be with the animal. That person that is with the animal, does it have the adequate knowledge to know if changes are occurring in the animal? Can this person monitor the necessary parameters in the animal? That is very vital. You need adequate equipment. We're going to look at the equipment later. You need your fluids, and sometimes you also need drugs in case there is an adverse effect. And you need adequate monitoring device. Next slide, please. Next slide. Okay, I think I've talked about personnel. You need trained technical staff that is proficient in assessment of patient fluid status, not just anybody that can assessment. And if there is a shift in the catheter, can use the equipment well, can monitor well, and can assess the risk of fluid and drug incompatibility. So it's not just anybody that you can place and ask to monitor the animal well when undergoing fluid therapy. Next slide, please. In terms of equipment, we need catheters, we need infusion pump. That actually is the best. But where infusion pump is not available, you can use a gravity flow system, which is what we normally use. That is the flow set. And then you need what we call lower lock connections, so that the animal or the personnel will not mistakenly remove the flow system from the catheter. Please, can we move to the next slide? Just run quickly to the next slide because I'm just showing the equipment. Yes, this is a typical infusion pump. Now, what the infusion pump does for you is that it helps you to regulate the flow rate. Instead of you counting and you are trying to adjust, flow is not too slow, it's not too high. The infusion pump can do that for you automatically if you have access to it. Next one. Yes, this is the typical catheter. I know a lot of us will use cannula. The problem, and we use what we call scalding needle. The problem with scalding needle is because it's a needle, it irritates the blood vessels. And when it irritates the blood vessels, it causes inflammation of the vein. resulting in phlebitis, what we normally say that the vessel are tissued. So if you want to prevent this, the best thing to use are the intravenous cannulas or catheters. Next slide, please. Yes, this is a lower lock system that prevents inadvertent removal of the flow system from the cannulas. Next one. Okay, these are double lower lock. In this one, you can actually, continually give your fluid and also administer drug. Instead of, the normal practice, when you want to administer drug, you will have to remove the flow set from the cannula, and then you introduce your needle and syringe. With this kind of double lower lock system, you can do the work simultaneously. Next slide, please. Okay, so let's have a little bit of knowledge about the fluid that we are administering. Naturally, fluids are classified into two major groups based one on the constituents, and the two major groups is colloids and crystalloids. Crystalloids are what we call multi-ionic solutions. You have several components there. We can also classify them based on the osmolality. So we have hypertonic solutions. These are fluids that will raise the osmolality of the fluid when you deposit it. We have isotonic. The osmolality of this fluid is similar to the osmolality of the plasma fluid. And then we have the hypotonic solution. Now, what it means is that if I administer an hypertonic solution to a compartment, it will draw water from the adjacent tissue into. If I administer an hypotonic solution into a compartment, water will move from that compartment because it's hypotonic to the adjacent compartment. And that is why it's important. It's not just about how this animal is dehydrated. You also need to know what is going on. What is the osmolality of each of the compartments? And lastly, we can group them based on their need. Do I want to use it for replacement, or am I going to use it for maintenance? Next slide, please. So what are colloids? Colloids are fluids that are retained more easily in the intravascular spaces. And because of their osmolality, they increase the osmotic pressure of the intravascular space. Also, they have the capacity to deliver greater percentage of oxygen than your crystalloid will deliver. And they stay longer in the intravascular compartment compared to the crystalloids. Next slide, please. However, they have some disadvantages. They can cause cardiac failure because of their osmolality. They can result in pulmonary edema because they are increasing the osmotic pressure of the blood, and they can result in peripheral edema. Some of them are proteins, and because they are proteins, the body can react to it and result in anaphylactic reactions. And apart from that, they are quite expensive. The cost of a colloid is almost about 10 to 15 times the cost of your usual crystalloid. Next slide, please. So when will I need my colloid? Colloid is required when you need to administer large amounts of fluid rapidly, and it is difficult to do that. For instance, an animal is dehydrated. At the same time, this animal has a very low PCV. There is very high dehydration, and also there is very low PCV. The high dehydration means that I need to administer a lot of fluid. The low PCV means that if I administer too much of fluid, it will affect the oxygen content that is getting into the tissue. So I have a dilemma. In such a case, what do I need to do? Instead of administering a crystalloid, it is better to administer a colloid. Number two reason is when you want to achieve greater cardiovascular benefit using minimum amount of fluid. And the last one is when there is large volume losses. Next slide, please. So here are the examples of colloids that you can try. We have imacil, we have plasma protein fractions, we have albumin, we have dextran, we have beta starch and gelatins. Next slide, please. Okay, crystalloids, like I said, they are multi-ionic solutions. The advantage include one, there is no adverse anaphylactic reactions that we see in case of colloid with them. And because they are, most of them, they are actually isotonic. Yes, few of them are hypertonic, hypotonic. They don't cause so much disturbance to homeostasis. And most importantly, they are cheaper than the colloids. Next one. So the problem is where you need to administer large amount of fluid and you want to use crystalloid. When you do that, that could result in peripheral pulmonary edema. And because they are crystalloids, they don't stay in circulation for too long. That is the reason why sometimes when you administer this fluid, by the second day, the animal is back into, into shock. And you are wondering, but we gave so amount of fluid to this animal. What has happened? Remember, they don't stay in circulation for too long. Exactly. And the other problem is that larger volume or longer time is required before you can achieve fluid balance. Next slide, please. So what are the indications? One, when you have extracellular volume depletion, you need your crystalloid. When they say you have a case of hypovolemia involving the extracellular fluid, that's basically in case of dehydration. Number two, when you need to replace intracellular fluid. And the last one is when there is a symptomatic hyponatremia. Next slide, please. So what are the examples of crystalloids that we have? We are very familiar with these ones: normal saline, dextrosaline, Ringer's lactate, 5% dextrose, our Hartmann solutions, and the rest of them. They are the crystalloids. Next slide, please. And here I'm trying to show us the composition of the different crystalloids that we have and some colloids. Thank you. Next slide. So let's quickly go through the essentials. What are the things that I need to do if I want to have a successful fluid therapy? The first important thing is you must evaluate the patient and determine the need for fluid therapy. Don't just say because the animal have the history of diarrhea or vomition that you are just going to. No. Do a thorough evaluation of the patient. What is the heart rate? What is the respiratory rate? Auscultate the lung. Auscultate the heart. Is the heart regular? Is it irregular? Do we have comorbidities? It is after you have determined all these things, evaluate the level of fluid loss. It is after you have determined and established all these facts that you can then say, oh, we need fluid therapy. And this is the type of fluid that we need to use. The second thing you need to determine is the level of imbalance, either of the fluid or the electrolyte. Okay, what type of fluid or electrolyte imbalance do we have? Is it a volume deficit? Is it a constituent deficit? If it's a volume deficit, is it hypovolemia or is it hypervolemia? Those are things that you must determine. And once you can do the first two, then it is easier for you now to say, oh, this is the fluid that we need to administer. You can select the right fluid. And then you can then determine how much you want to administer. What's the quantity that we need to administer? There is no hard and fast rule about fluid therapy. In fact, there is no singular method. Fluid therapy should be tailored towards the patient. It should be specific for each patient because each patient is unique on its own. Next slide, please. Next slide. You need to determine the route of administration. It is not only the intravenous route that you can use. There are several routes that fluid can be administered through: oral, subcutaneous, intraperitoneum, intraosseous. So you need to determine the routes that you want to use. Here I'm giving you the list of the things. Okay, please, can you, okay, I'm okay. Yes, it's okay. These are the list of the things that you need to check out from the animal if you are going to be able to successfully administer your fluid. What's the pulse rate? What's the quality of pulse? Capillary refill time, mucous membrane, respiratory rate and effort, lung sound. What's the lung sound like? Skin sugar. What's the body weight? What's the rate of urinary output? Because that might be indicating that the kidney of this animal are shut down and you want to administer fluid quickly so as to open the kidney. Mental status. Is the animal conscious? Is the animal alert? Is the animal active? Or the animal is unconscious? What's the temperament of the animal? Because that will determine the route. Some animals, they don't need fluid intravenously. A very active temperamental animal, there is no point trying to say, I want to give fluid intravenously, because the animal will keep on disturbing. And what you notice is that the instrument will keep on coming out. So you're going to have phlebitis in several places when you don't need it. So eventually, when you need it, all the veins have collapsed. So you don't want to do that. And that's why temperament of the animal is also very important. Total protein, serum lactate, again, all these ones you can determine it when you take blood sample for analysis. Next slide, please. Okay, so what's the minimum laboratory evaluation that we need to do? One, you need a complete blood count, because that will tell us what's the PCV. If we administer fluid, are we going to dilute or we are not going to dilute? It's also going to help us the ability of the blood to transport oxygen to the tissue. We must determine the electrolyte, the urea, and the creatinine from the blood. Serum electrolyte, serum urea, serum creatinine. It's giving us two things. It's telling us the electrolyte status. It's also letting us know how the kidney is functioning. And then you also need to determine the urinalysis. Urinalysis will give us a lot of information about the kidney function of that animal. Next slide, please. When you finish your evaluation, one of the things you want to establish is, are there comorbidities? Yes, the animal came to you because he has diarrhea. But there may be some comorbidities that can complicate the management of the diarrhea. For instance, in parvo, an animal that has parvoviral enteritis may also have cardiac problem. Now, so the problem is not just the parvoviral enteritis. If you don't manage the fluid very well for an animal that has a cardiac problem, you just notice that you wake up one day and the animal is dead. Not because of the enteritis, but because of the cardiac problem. So that is why it's important for you to determine comorbidities. Do we have congestive heart failure that will make the blood not to move the way it's supposed to move? That will make fluid not to move the way they are supposed to move? Do we have pulmonary edema? Do we have renal problem? Do we have liver problem? These four things are important comorbidities that will affect metabolism as well as the movement of the water. Next slide, please. Next slide. Thank you. So how do we classify the disturbance? The first one is change in volume. It's only the volume that is affected. Example is dehydration. In dehydration, the problem is that the volume of fluid in the interstitial compartment has reduced. So that is what you want to replace. Or maybe there's a blood loss. In case of blood loss, that's hypovolemia. The problem is that the volume of fluid in the plasma compartment is reduced. So we can have change in volume. We can also have change in content. The volume is okay, but the electrolytes that are present in different compartments, they have been disturbed. For instance, like I told you, potassium can leak from the intracellular compartment and move to the extracellular, and it will get into the blood, causing hyperkalemia. So you want to determine now, what do we have? Is it changes in volume or changes in content? Or even changes in distribution? Is it that the amount of fluid we have in a particular compartment is more or less than what we are supposed to have in that compartment? So these three things you have to determine, and that will now determine the kind of fluid and the rate at which you want to administer. Next slide, please. So again, I mentioned earlier that there are several ways that you can use to administer your food. In fact, the best route is the oral route, because it maintains normal GI activity. That's the best route. But when the animal is vomiting, this route may not be feasible or is not advisable. Or probably when the animal also is unconscious. You cannot be giving food to an animal that is unconscious. So you have to try other routes, like the subcutaneous route, especially when it is not possible for you to maintain and to monitor fluid therapy. The subcutaneous route might be a feasible route. The intraperitoneal route is used when you cannot access the intravascular, when you cannot access the blood vessel, then you can use either the intraperitoneal or intraosseous route to administer your fluid. But you have to be very careful about intraperitoneal so that you don't put fluid inside the abdominal cavity. That will cause ascites and not fluid therapy. The intraosseous route is also available, and then the one that we are very familiar with, which is the intravenous route. Next slide, please. Well, I've given advantages of the oral route. That is the best when it comes to fluid administration because it maintains GI function. Number two, there is risk of infection. It's very, very minimal, except you use a very bad fluid. And I told you the only reason why we don't administer or that we contraindicate is when the animal is vomiting or when the animal is unconscious. Now, one of the problems we do when we are giving oral fluid therapy is that we don't monitor it and we don't plan it. We just put fluid inside the bowl for the animal and we expect the animal just to be taken. No, when you want to use your oral fluid therapy, you must measure the amount of fluid that the animal is going to be taking regularly. It's not ad libitum administration. Next slide, please. Next slide. The subcutaneous route can be used for administration of fluid at home. That's when you cannot, monitor. You can also use it in conjunction with other routes, like the intravenous route, especially when you cannot administer large amount of fluid intravenously. You can use it as a support. And again, when it's difficult for you to secure venous access. When you are doing that, you also have to be very careful that you don't create what we call generalized subcutaneous edema. So you also have to determine, you have to be careful the amount of fluid that you are administering subcutaneously. And the fluid you are administering subcutaneously must be the fluid that can easily move to the intravascular and intracellular compartment. Exactly, meaning that you cannot administer an isotonic solution subcutaneously. If you do that, it will draw more water to the subcutaneous tissue, and that will worsen the condition of the animal. Next slide, please. Okay, intraperitoneal fluid, I've mentioned that, and I think I've told you what you need to be careful about. Next slide, please. Next slide, please. Yes, intra-issues, I know we are not familiar with it. We don't do this commonly, but this is something that you can do. The intra-issues route is a route that you can actually use when you are dealing with, especially all these small animals, that it's very easy for them to have vascular collapse. You can use the intra-issues fluid administration technique for them. Next slide, please. And then the commonest one, which we are all familiar with, that's the intravenous fluid. It allows you to administer large amount of fluid over time. But we have to be very careful when we are using the intravenous route, because the risk of infection is quite high there. And that's why it's important that you should maintain your asepsis when you are administering fluid intravenously. Next slide, please. Okay, so what are the conclusions? What are the take-home for today? One, fluid therapy is important for medical and surgical conditions in veterinary patients. However, the assessment of the patient history, the complaint, the physical examination finding is very important for you to determine the patient needs for fluid therapy, the type of fluid disturbance that is present, and the type of fluid you are going to administer. Thank you very much. I think we can take our questions. Thank you.
Thank you so much, Prof. That was professorial. And that was really very extensive. We already see questions coming in. But before we take those questions, I'd like you to also still keep the questions still coming in. It's important we keep getting the questions. But before that, I just want to quickly acknowledge some very important persons amidst us. I've not been able to compile all the lists, but let me read out the first. Thank you, Professor Akinloye, the Dean, Faculty of College of Veterinary Medicine, Abeokuta. Professor Akinloye, thank you. Dr. Ganiel Nahoro, the Chairman, Continuing Education Committee in the Council. And recently, and congratulations, Dr. Gani, recently he was appointed by the President of the Federal Republic of Nigeria to participate in the Senior Executive Course, National Institute for Policy and Strategic Studies. So he's joining in from Jos. We have the very famous and the most proficient small animal practitioner that we have in the country, a foremost veterinarian who has trained a lot of people, Dr. Kunle Abiadi, also in the house. We also have the president of the Commonwealth Veterinary Association, Dr. Olatunji Nasiru, listening from Canada. I spoke with him this morning. He said he's in Canada. We have Professor Omobo Wale, also a very strong hub expert that we have engaged constantly. We also have the president of the Nigerian Veterinary Medical Association, Dr. Olutoyin Adetuberi. Thank you so much for joining. The chairman of the Lagos State MVMA chapter chairman, hosting the convention this year, Dr. Mark Ofwa. Thank you for joining. We have my director of veterinary services, Lagos State, also on the call. I will be looking out at the role, and then I will be mentioning names as we progress. Right now, we want to get Dr. Teresa's perspective. So I'm going to be enabling her, spotlighting her for everybody. Let her share with us some experience. I also hear she has a video that she wants to share with every one of us. So not the case study now. So can we stop sharing the screen so that the back end can also share her video? She has a video she wants to, but Dr. Teresa, good to have you around. You've made money doing food therapy. You've made a lot of money doing food therapy. So we want to hear from you. How do you make the magic happen? Go ahead, you have the next 5 minutes.
Yes, thank you. And in fairness, Professor Ajadi has done wonderful. The job is excellent. He has explained to us in details. How do you determine, okay, what kind of fluid do I choose? What kind of condition am I having, the test to carry out? So let's go forward to, okay, now I know the level of dehydration I've got? How do you determine the quantity of fluid you are going to administer? Are you with me? So we're talking about fluid volume to be administered in the patient. I'm choosing, for instance, the intravenous route of administration, which is very, very handy, like he had earlier mentioned, when you have a situation of like massive fluid loss, maybe from blood loss. And so that is, you're having a condition of hypovolemia. So now, how do you calculate? You want to, please note, there are 3 types of fluid you want to put into perspective here. The maintenance volume that you would require is the first thing. And then the dehydration you are replacing, the percentage dehydration you want to rehydrate. That's the second one. Then the insensible fluid loss that you could have had. By that, what do I mean? Your patient is still on the table, is still being taken care of, and then you're still having ongoing vomition, you're having ongoing diarrhea from urination as well. In the urine, you are still losing fluid. So that's the insensible loss. There is a way you want to calculate. So you add the 3 of them together. That's what will give you the total volume you are going to. And then another point I would like us to note is the drip rate. If you have now secured, how many drops per minute am I going to allow to flow in as to maintain equilibrium of the flow? That is an area I'm going to also shed light on. So I mentioned earlier the maintenance volume. So all the time, usually it's about G to administer lactated ringas, for instance, in a patient. So how do I know how many mils of the fluid? I said 1, the maintenance volume. 60 mils of the fluid per kg. So if a patient that is about 10 kg in weight, so that means 60 mils times 10 to be administered over the next 24 hours. That would be my maintenance required. Secondly, I said you will add this to your dehydration replacement volume, and that will be determined by assessing, like what Prof said earlier, you assess the level of dehydration. We usually express this in percentage, and it ranges between 5% to about 12%. Goes beyond 12%, then the patient is in shock. So if I say and then if we are about 6 to 8% dehydration, then you're going to see there's loss of sugar, that the skin elasticity is going, not completely gone. There will be dry mucous membrane. You have depressed globes. You can, if it's mild dehydration, you probably just see a mild sugar loss, and then you put that about 5 to 6%. But when we're having about 10 to 12%, then you are having a critical situation. The mucous membrane should be completely drained, dehydrated. The globes will be completely depressed or will be completely lost. So you've determined initially the maintenance volume. We're talking the dehydration has been determined also, let's say at about 8% now. You multiply that factor you are determined by the weight of the patient, and then you multiply by 1,000. So in the example I had given earlier, my patient is about 10 kg, remember? And I've determined it to be about 8% dehydrated. So 8% times 10 is 80, multiplied by 1,000 will give me the volume of dehydration replacement I'm going to do. We will now add that to the insensible loss, fluid loss. Like I said, if there is continuous vomition, there is continuous diarrhea in urination, all those fluid being lost still while your patient is being treated, we'll consider it. And there is a formula for that as well. Consider about 0.5 to 1.5, but I usually use 0.5 multiplied by the maintenance volume I got initially. You know, I said maintenance volume, the formula is 50 mils to 60 mils.
So I want to be sure if the network issue. Okay. So I think it's we cannot hear her. So I need to be sure if the issues is coming from.
Network with your fellow residents from across the 11 veterinary schools we have in the country, and there are a lot of package installed from the public lectures to the cultural trip to the bonfire to the dinner and after party. So we're going up a picnic and the meet and greet where you get some other students that are coming, and also we are.
All right, so I think, hello, we kind of lost her. Mr. Isaac, if you're at the back end, she shared the video with us. Can you kindly just share the video so while we wait for her to reconnect? So there are two ways we can either share the video she shared with us. Are we set to share the video at the back end? Okay, so go ahead, kindly share the video while we wait for her to rejoin. So what she had done is that she sent a 2 to 3 minutes video just to practically demonstrate how things are done. All right, fantastic. So I want to be sure we can see what's being shared.
So here we are shaving and preparing to sterilize for venous access in IV line. Ensure you maintain asepsis. A tourniquet is in place. The cannula has been put into the venous access, and then we are ensuring that there is free flow, and then we're going to secure the cannula in place. The tourniquet is being released. We are flushing the line. You secure with tapes to prevent accidental removal of the cannula and subsequent attendant bleeding. Note the technique of the taping that was used. This will ensure proper securing of the cannula in place. After this, you can then administer medications continuously and attach your fluid. We've stopped the flow of the IV fluid now, and we are administering some medication. Always try to go slow IV when you are administering medication.
All right, so I think that's about it. Unfortunately
So
for us,
here
she's
we're
back.
shaving.
Okay, so Ms.
preparing
Isaac, I think you can stop the video
sterilize.
at the background. She's back. So you just have probably around 2-3 minutes again. Madam, welcome back. I know your network was interrupted.
Yes, sorry about that. So in summary, I've said as a recap, the total volume of fluid you want to administer, you've determined the type of fluid. I said the maintenance volume has a formula to it, 50 to 60 mils per kg per day for the next 24 hours. You add it to the dehydration coefficient, which is in percentage, which is determined from that example I gave, multiply by weight and multiply by 1,000. Sum that up to the insensible fluid loss, which I said can easily be obtained by multiplying 0.5 coefficient by the volume, maintenance volume earlier derived. When you sum this up, it gives you the volume you want to administer to your patient. And as a rule of thumb, you usually should administer about 1/4 to half of the volume in the first 2 to 4 hours. And then you stabilize with the remaining fluid. You spread it over 24 hours in critically ill patients, and that will help to stabilize them mostly. So now you've determined the volume. How do you set the drip, the flow rate? If you check on the infusion pack, usually they write about 20 drops per minute is about what you get. So the 20 drops will make a ml at the rate of flow. Usually the type of drip flow we use, the macro drip flow. So to get that volume, you are going to drop the
I think we're still having
the total volume of fluid as indicated on the drip day times how many minutes, which is 20, you have calculated. That will give you, and then you set it up, and that's it. Hello?
yes, we can hear you, but you were somehow breaking.
Okay, just let me replay the drip factor, the rate, the IV rate. We have determined the volume, and I said the total volume determined, you multiply it by the drop factor as usually indicated on the pack. It's indicated 20 drops per minute. Usually an equivalent of 1 ml. So you multiply it and divide by the number of minutes, which is 24 hours multiplied by the 60 minutes you've got. That will give you your flow rate per minute. So when you get that, you want to adhere to it and use it as a guide to avoid fluid overload, which can easily lead to a lot of problems which you wouldn't want. So that's it basically on the fluid rate.
All right, so thank you so much. I guess there were questions already on ground for you. Maybe after this session, we could just put together everything you have said in one page and do it as part of the email we are going to be sending to our participants. We are almost at the interactive session, but we need to pick a case presentation. After that, then we will now open the conversation for questions, answer, and then the back and forth. We'll have another 5 minutes for an actual case that one of us will be presenting. Dr. Samuel, is he on board? Can we make Dr. Samuel and then let's share our screen? We need to do this quickly so that we can get into the interactive session as soon as possible. Can we make Dr. Samuel Abiodun co-host? Dr. Abiodun. Yeah.
Yes, sir.
Fantastic. So you have another 5 minutes, so you probably need to rush because of our time, so that we can still spend the next 40 minutes doing, 5 minutes.
Okay, sir. Thank you very much. Thank you for the opportunity. Almost everybody is my teacher, including Prof. Ajadi, who I mentioned yesterday that he vivaed my surgery final exams. Thank you so much for the opportunity from Malat. Well, I was told 10 minutes, so I just gathered about 3 cases where I used fluid therapy, but I'll just rush through all. We can move, please. Thank you. So this is Ami, a 2-month-old female bull with complaints of vomition, bloody diarrhea, lethargy, abdominal pain, inappetence, and weight loss. And there's no history of vaccination. And Ami is a home pet to her parents. Next slide, please. So upon physical examination, she had a temperature of 38.3 degrees Celsius. The mucous membrane was pale. Capillary refill time less than 2 seconds. That rate about 132 beats per minute. Percentage dehydration 7%. So I do my percentage dehydration like Prof and Dr. Tessie said, using skin tests, capillary refill time, and the mucous membrane. If it is, like she said, if it is less than 5%, it is mild. How do I know it is less than 5%? The skin test, the capillary refill time will be between 1 and 2 seconds, and the mucous membrane will be semi-dry. If it is moderate, about 5 to 8%, and the skin test will be about 2 to 3 seconds, including the capillary refill time, and the mucous membrane will be dry. It is severe. If it is greater than 8%, that's 3 seconds, greater than 3 seconds of skin test, capillary refill time, and the mucous membrane is very dry. I'm sure we know how to do the skin test and check the capillary refill time. Ami's weight was 7 kg, and we had to, of course, have tentative differential diagnosis. Are we looking at the history, the physical examination? Are we looking at hookworm, dietary indiscretion? Are we looking at giardiasis, bacteriosis, salmonellosis, pancreatitis, and the list go on? And including, of course, suspecting canine parvoviral infection. It can be any of them. It can even be hypoadenocorticism. It can be inflammatory bowel disease and all. Next slide, please. So to confirm with having all the differential diagnoses, we started to collect blood sample for laboratory investigation, hematology, and serum chemistry. So looking at that, what we have, the plasma erythrocyte, we can interpret this now. We can see that the puppy is mildly hypoproteinemic and mildly anemic, and that protein, total protein is about 5.3. It should be between 5.5 and 7.2, the range. So the puppy is mildly hypoproteinemic and mildly anemic, and the hypoproteinemia suggests a blood loss and hemorrhagic issue, as indicated by the bloody diarrhea at the melena. And let's look at the leukogram. Next slide. Okay, thank you. We can see the leukogram, the total white blood cell differential and all. We can see from this result that the leukogram is showing a mild leukopenia characterized by significant low lymphocytopenia, which is of course suggestive of a likely viral infection. So we should be ruling out acute viral infection, especially parvoviral enteritis. Because like I mentioned, I put the date there, it was around January and a lot of parvo cases there. Next slide, please. So with my, next slide, with my hematology, I decided to do a parvovirus test and it came out positive. Next. So I'll be focusing strictly on the flu therapy. Thank you. On the flu therapy for all these cases because of time. And it's also expedient to note that intestinal form of canine parvovirus drastically reduces our patient's ability to absorb nutrients. And that means that this particular patient, Amy, will quickly become dehydrated and weak from lack of protein absorption. So fluid replacement for the losses incurred through the vomition, the bloody diarrhea is the cornerstone of my treatment. So I had to replace these losses, okay, through fluid therapy. And I had to decide, am I using crystalloid, colloid, or blood product? Of course, I chose to use crystalloid. So am I using normal saline or lactated Ringa? So what I do for every of my cases to choose the fluid choice for my therapy is what are the clinical signs, what is lost, just like Prof said. So here we have vomition in diarrhea. Most times in vomition, we have sodium loss, potassium loss, chloride loss. In diarrhea, we have, in acute cases, sodium. In chronic cases, potassium. Potassium, thank you. So which of these did I use for Amy? Next slide, please. So now that I know the ions lost in these cases, that's in these conditions, vomition and diarrhea, I looked at the two crystalloids I'm thinking of using. Normal saline contains sodium and chloride. Lactated Ringas contains sodium chloride, potassium chloride, calcium, and of course sodium lactate, and also Ringas solution. The only difference between Ringas solution and Ringas lactate is that Ringas solution contains sodium bicarbonate, which is more balanced. So I chose to use Ringas lactate, and I gave an infusion dose rate of 70 milligram per kg IV daily. Normally, they say that the rule of thumb for maintenance is about 90 milligram. For conditions like this, about 90 milligram, maintenance about 40 to 60. So I just chose 70, like Prof said, each patient with its own peculiarities and idiosyncrasies. Also, I considered urine output, which is about 1 to 2 ml per kg per hour. And yes, I used Ringas lactate I infused Ringas lactate as my fluid therapy choice. And like Dr. Percy said, I do my the volume of fluid to be administered using percentage dehydration and body weight, or dose rate and body weight. So the dose rate for, sorry, yeah, I'm almost done there. So I like I said, my dose rate is 70 ml per kg. So I multiply that by our weight, that is 7 kg. And that will give us 490 ml daily. Also, if you use the percentage dehydration, it will also give you the same 490 ml daily. Percentage dehydration is 7%, body weight is 7%, 7 times 7. So the same thing. Next slide, please. And I also chose to use, intravenous route because, just like Prof said, sometimes we choose to use, we choose subcutaneous route. But most times I avoid that, especially in severe dehydration because of peripheral vasoconstriction. So puppies are actually prone to hypoglycemia because of anorexia, long-term chronic anorexia, especially with canine parvoviral enteritis. So following the rehydration with Ringas lactate, I gave 5% dextrose, which will help supply some energy to the cell. So that's on day 4 for 2 days before and day 5. So coupled with other therapy indicated for parvoviral enteritis, Amy was back on her feet, and the quantity of fluid was of course reduced gradually as she came. Next slide, as she regained appetence. So this is Amy. You can play the video, please.
So Amy is alive.
Yeah.
Congratulations,
Okay.
doctor.
So
I'm afraid we have to stop at that just one case, so that we don't run the program with a lot of cases, if you don't mind. Do you?
It's fine.
All right.
It's fine.
Thank you so much. But hang around. I want you so that if there are any questions and expert advice around the case you've just attended to, it will be good that you stay and face the fire. There's a lot of prof in the house, so I guess your cap will be off very soon. All right, so I think I want to open up the interaction now. I'm going to be spotlighting Professor Jadi, who is our hub expert can you stop sharing the screen? And then I will also be spotlighting Dr. Teresa so that we all can come on the spotlight. Now there are a few questions. We are now here to start interacting. I can see Dr. Tunji Nasir raising up his hand. I don't know whether he wants to ask a question or he wants to add to the conversation, because I think he's also one of those brilliant small animal practitioners that we have in the country. But let's do this. Let's take Professor Jadi first. Dr. Tunji Nasir, just permit me, I will be calling you up shortly. Professor Jadi, from all your experience, what do you think are the common mistakes, 2-3 common mistakes that young professionals make when administering fluid? Just in summary, before I start picking up those questions. Okay, you are muted. You will need to unmute yourself.
I think I've done that now. Thank you very much. Well, the 3 mistakes are same. One is, number 1, planning is not adequate. That's the first one. The second one is that they do not have the capacity to do that. I've seen a lot of the young ones, they want to administer fluid at home of the clients. Fluid therapy is not something that you just do for 2 to 3 hours. Like Dr. Tessie said, it's supposed to be administered for 24 hours. So if you administer what you're supposed to give in 24 hours, you give it over 2 hours or 3 hours. What you are doing, creating is hypervolemia. And that's why we run into trouble with most of the animals. Probably the third thing is what you are trying to do is a knowledge. Quite a number of people do not actually have a knowledge. Yes, we know that the animal needs feed. We know that the animal, this is the feed that we can use, but what steps we need to take? For instance, you see a lot of people administering feed. They have not done the basic laboratory examination that we talked about. The complete blood count, the little chemistry they are supposed to do, urinalysis. If you don't have those information, there is no way that you can have a successful feed therapy. Thank you.
Thank you so much, Prof. I've also noticed this, some of us young professionals, all right, so I see very senior colleagues raising up their hands. I'm going to be calling shortly. I've noticed this. I'm also a young vet. We got in a young vet, and he was administering fluid without any calculation and without even exactly knowing what he was doing. And afterwards, after a few hours of administration, the puppy died, and there was a lot of issues around the case that time. So for every young professionals, I think it's appropriate we pay attention. Fluid is not just fluid. There's a science behind fluid, as we all know, and we need to adhere strictly to whatever it is that we are learning from here. But let me quickly, before calling on Dr. Teresa, Dr. Tunji Nasir wants to say something, and then I'll give Dr. Ganitu a small space, hoping that he asks a question. Dr. Tunji Nasir, go ahead, sir.
Yeah, thank you, Dr. Femi Kari. And I really want to thank Professor Jadi for the very highly enlightening presentation, and also Dr. Tessie and the case presenter. I'm very, very impressed with what we have done today. But my concern, and that would be to Dr. Jadi, I will have a bit of some question playing the devil's advocate, and maybe some other observations within the next. In the management of parvoviral enteritis, we know that in parvovirus enteritis, a lot of the times potassium is lost, and is one of the constituent losses that would always affect the outcome of the case eventually, because potassium loss will cause muscle weakness, cardiac muscle weakness, skeletal, everything. It's going to cause a lot of muscular weakness and all that. And then eventually the puppy may likely, or the subject may likely pass away. But the thing is this, how do you now to parvovirus enteritis? How do you determine the parvovirus? Because a lot of the time, like you rightly said a few moments ago, people don't even do laboratory investigation diagnostics for them to even know that, oh, and all that. And again, it's something that is also needed to be done serially to monitor the response, of some of these puppies to, to the replacement and everything. So what would be your own advice? Because I'm of the opinion that a lot of the time people don't really have the access to some of the ways, in which they can also like determine the losses of the electrolytes and all that. What would be your own suggestion to, like Femi will always say, to the young vets, who is not very conversant with determining these things? That is one. Then number two, I see the issue of hypervolemia, overhydration as a big problem. A lot of people have lost a lot of puppies, a lot of patients to overhydration. And it is because of one thing, that they have not actually calculated very well. And sometimes they have rushed the fluid that they should give over 24 hours. They give it in about 3 hours because they want to close for the day and all that. But there are some local signs that I know, and I'm sure I want you to have either support or maybe, I don't know what to say about that, but it's like, I noticed that sometimes you have constant urination. You have increased urination during the time you're giving the fluid. If you are really, really overhydrating, there will be over-urination, there will be difficulty in breathing. You see the puppy or the patient all of a sudden having, difficulty in breathing because of pulmonary edema and all that. Then sometimes locally, I also notice that you see fluid dropping from the nose, dropping from the nose, you see it. And again, you see that your dog that is a bit stable becomes a bit confused, it becomes confused, maybe already having some edema somewhere that is not supposed to be. So I noticed this, and I don't know whether you want to corroborate those my observations that I noticed in overhydration, or there are other things to be had, or we can delete from that. But the basic question I'm asking you now is the position of potassium replacement, in parvovirus enteritis. And I also noticed that a lot of us, we just concentrate on lactated ringers. We've forgotten that we have fluids like full strength arrows, half strength arrows. And I also noticed that the percentage, the potassium in half strength arrows is high, very high. So sometimes when I think I'm losing a lot of potassium, I usually change to some specific fluids and all that. But these are all for you to either corroborate or maybe tell us more about them. Thank you.
All right, Prof, I think over to you. No comment from me.
Thank you, sir. Thank you, my Oga, Dr. Nasser. Yes, you have two questions here, or two comments that you want me to talk about. First, the potassium replacement issue, or animals that have potassium deficit. Like I said earlier, it's not just important to know that these animals require fluid. It is important to know what, a lot of the things we do is academic, what we have been taught in school, that, okay, when an animal has diarrhea, this is what it lost. It's lost. And because of that, we map out. But like I said, each animal is individual. The fact that potassium is lost in dog with diarrhea does not mean that every dog at that point in time has a loss of potassium. And that is why it is very, very vital that the minimum laboratory examination that we said we should do, you should do it if you want to record success. Now, where that is not available, but again, I don't see anywhere in Nigeria where you can be that you cannot. Yes, you can start with administration, but before you do that, collect your sample, send it to the lab. And while you are waiting the sample, you can start with administration by the side. And as soon as you have your result, that can then help you to, that can inform you of what other things you need to do. But that you will continue to administer fluid for several days without a lab analysis will not be too ideal. That's what I mean. But like Dr. Nasir said, yes, if there is a potassium deficit, what deficit? Is it hyperkalemia? Is it hypokalemia? If there is hypokalemia, which is deficiency, then we can go to Darrow solution, whether half strength or full strength, depending on the level. And that's where the lab is also very important. How much of hypokalemia do I have? So that's important. If it is hyperkalemia, then what I need is a diuretic to take care of. No, is it hypokalemia or is it hyperkalemia that I'm dealing with? Now, in terms of the second question, overhydration and hypervolemia, all that Dr. Nasir said is correct. And that's why initially you recall that I mentioned that you needed trained personnel. All that he said, it's not just anybody that can do it. A trained personnel is very important. This is not where a secondary school dropout, you ask him to be monitoring an animal or fluid. It will not work well. It will not go well. You need people that are trained to be able to monitor, to be able to identify some of this problem. Now, also, you'll notice that I did not mention anything about rates. I did not mention anything about dosage of fluid. It is deliberate. And why it is deliberate is because the rate that you use is a function of what type of fluid you are using. Is it a colloid or a crystalloid? If you calculate a colloid using the 70 ml per kg per day, the animal will die because there is no way you are not going to overhydrate that animal. So I intentionally did not mention because the volume or the dosage and the rate is dependent on the type of fluid that you are administering. So please understand the basic science, the basic mechanism, and then you can determine, okay, which fluid am I going to use? If I know the fluid I'm going to use, then I can calculate the dosage. Because the dosage is not constant, depending on the type of fluid you are using. Thank you very much.
All right, thank you so much, Prof. We have so much to cover. Let me take Dr. Teresa, then I will unmute Dr. Gani and Nahuru to probably also say something, and then I have Dr. Anatu and Dr. Shegun to come on board. But for Dr. Teresa, so what Dr. Tunji Nasiru ended with, it's I've seen it. It's very common. Young birds just go ahead and administer fluid, although they must have told the client, you know, we have this cliche that parvo is 50-50. So even though if the puppy or the dog is dying based on your own mistake, you had already prepared the client's mind. So have you lost any case that you were administering fluids, and are there any lessons you want to share with us? Can she hear me, Dr. Teresa?
Yes, thank you. Can you hear me?
Yes, we can hear you now. Loud and clear.
Yes, thank you. So it's quite simple. There is need for a lot of monitoring. You don't just set up fluid and rush it.
Your network is shaky. Your network is shaky.
We have to do better than that. When you are in fluid administration, you have to be better now. What is it about this? Is it better?
It's still shaky. Still shaky. Maybe if you could connect with your phone, they will allow you in again. Do you mind?
Is it better now?
Okay, yes, we can hear you now. Or you can put off your video so that you can have
Yes,
better
what I'm
bandwidth.
saying is, okay, minimize the video. It's off.
All right, fantastic. Go
Okay,
ahead.
is it better now?
Yes.
Yes. So in summary, what I'm saying is fluid therapy is not to be rushed. You take your time, you observe your patients. Like Dr. Tunji Nasri said, there are symptoms, like he said, you are beginning to see edema, you're beginning to see pulling in the peripheral, in the extremities, you watch out for those. And like I said, it's slow. After the initial 2 to 4 hours, you slow it down, the rate reduces, and then you watch how your patient is doing. And then you're not just going to continue for several days, you could run into fluid overload. You understand? And that could easily create a lot of problems than you were expecting. And should the case arise in which you are finding a situation, okay, there's edema now, what do I do? You don't just leave the pet to die. You don't abandon the pet. You can administer diuretics. You understand? And then you can carry out paracentesis if you've seen that, okay, there's fluid accumulation in the abdominal cavity. And then you advise restriction of salt intake. And then you watch closely. There is need for observation. And then continuous laboratory testing. You want to see what is going on. You want to carry out tests like as simple as the PCV. If you create too much hemodilution by administering too much of fluids, what am I going to have? You're going to have a marked reduction in the oxygenation of vital organs, and that could actually lead to death. So one of our rule of thumb that helps us is a lot of monitoring, paying close attention to the patient on fluid. You don't set line and abandon the patient and go, or rush it and then drop the patient in the kennel. These usually are critically ill patients that need a lot of monitoring. Thank you.
You know, okay, all right. So to just pick up from that, somebody was also asking whether you can attend to 5 to 10 dogs at a go. Maybe that person, due to economic reasons, wants to admit. Of course, from what she had said, if you don't have the capacity, Professor Jadi also mentioned that. I think it's better you refer to people who have the capacity to handle. So when you're administering fluid, Dr. Tessie said you need a lot of monitoring, and that requires you to be on ground and not attending to 10 dogs at the same time. Dr. Ganya, I want to quickly unmute you. After Dr. Ganya, I'm going to give Dr. Hanato and then Dr. Shegun a brief moment to ask their questions. Dr. Ganya, over to you, sir. And congratulations.
Thank you, Femi. Are you hearing me?
Yes, but slightly faintly.
Oh, okay. Are you hearing me now? Are you hearing me now?
Yes, sir.
Okay. Let me congratulate Famalat for choosing topics that are very topical and right on target. And you have chosen resource persons that are good enough. Very good. I mean, Professor Jadi, Dr. Tessie, Abiodun, they've done well. And then Tuji has also added some technicalities to it. I would not go into the technicalities again because most of the questions have been asked and answered. I just want to look at some of the practice, clinic practice aspect again, which Ajadi also have mentioned a little bit about.
So if you could speak, we could hear you, but if you could speak a little bit more audible, I think we will gain a lot from hearing you more clearly, sir.
Okay, what about now?
Better.
Better. Okay, good. I will not go into technicalities again because that has been very properly dealt with. I'm just trying to look at the practice management angles for fluid therapies. And I quickly will say that this is one area that all of us as veterinarians needs to develop expertise and skills. It's not enough for us to know what we need to do in terms of replacement of fluids, but what is more important is the capacity to be able to do it. And I've seen that quite a number of veterinarians have challenges in this respect. We need to use this capacity to differentiate between the quacks and ourselves. And it must be a profit center to every practitioner. Once you are able to confidently administer your fluids, once you have determined what you want to do, it is a profit center for you. That is one of the profit centers where the clients will not be able to start begging you as to how much charges you have given, because those are very special skills. So we need to be very mindful of that. The second aspect was to let you know that we must not say because we are waiting for laboratory results, not go ahead and sustain the life of the patient by administering normal saline here, pending when you're able to get your results after you've taken blood samples to the lab. What I think Professor Jadi may want to tell us over time from researches could be what level of sustenance should be done depending on the client or the patient, sorry, before the results come, and then we now go into specific. Because we can't wait and tell the client that his patient or his dog that is almost collapsing, nothing will be done until laboratory results are out. That's just the area I would like to emphasize before I run away. Thank you very much, Femi.
Thank you so much, Dr. Gani. Dr. Gani is the chairman of the Continuing Education Committee, the Veterinary Council, and also a consultant with FAO. As I said, nominated by the president to be on the senior executive course. Thank you for your contribution. He said, and for us private vet, we also know that if you really want to charge your client, let them see you administering drip. Up till now, you will not believe that some Nigerians think that you cannot give animals drip, administer fluid. So once you just set up the line, you see them pick up their phone, although we have restricted taking pictures from our clinic, but you see them pick up their phone and they want to make a scene out of it. And that will also enhance your billing if you know what you're doing. All right, Dr. Shegun, can you please unmute yourself and ask your question?
Yeah, good morning, everybody. Good morning to Professor Ajadi. That was a brilliant presentation. Dr. Tessie, that was a brilliant one. I got a couple of questions, but I'm going to limit it to just a bit to both Professor Ajayi and Dr. Tessie, and also make some contributions to what has been discussed. So my first question will go to Professor Ajadi on the use of the infusion pump. Maybe not a question per se, but maybe an addendum to that discussion, that is using the constant rate infusion when administering fluid. And perhaps I should also contribute to that it's advisable to use that when administering analgesics. I want to believe that would be one of the reasons you'll be using an infusion pump when administering fluid therapy. My second question to Professor Ajadi is on the oral route of administration. During your presentation, you talked about some fluids that can be administered orally. I would want you to shed some more light on what category of fluid, apart from edibles, we're able to administer orally, should we not want to use any parenteral route? And then I have 2 or 3 questions and contributions to Dr. Tessie. We're discussing about the fluid therapy regimen. She talked about the maintenance dose. I would also want to ask if she can give us any recommendation on the emergency dose and dosage and the rehydration vis-a-vis pediatric and geriatric patients. Let me just limit it to that so I don't take much of the time.
All right, so thank you so much, Dr. Shogun. Where do you practice? I'm eager to know.
I practice in Canada.
Okay, all right. I think Dr. Tunji Nasiru should maybe find time to see you. He also told me he's in Canada this morning. Thank you so much for bringing up those questions. So, Prof, what do you say? And then we hand it over to Dr. Tessie to also answer her own part.
Okay. Yes, I agree with the last speaker. I'm sure he's been using infusion pump. It's basically correct that when you want to administer drug, yes, you can use that. But beyond administration of drug, especially if you have an infusion pump that has some sensors that can pick up the blood pressure and some vital parameters, it can regulate itself, it can self-regulate. And also in cases where you need to, administer large volume over a period of time, I think infusion pump. But again, I'm familiar with our environment that probably you will find this only in the teaching hospitals. If it is not available, giving us an alternative, which is what we have been doing, our normal gravity flow, we can also do it. We can have our constant infusion. But like I said earlier, what is important is monitoring. I mean, we need adequate monitoring to make sure that things is not going out. He asked a question about the fluid for oral route. The basic fluid for oral route is the dextrosaline. So we can administer dextrosaline for animals. But again, I've given conditions. These are animals that are conscious, they are very active, but they have diarrhea once in a while, and they are not vomiting. We can use dextrosaline. Importantly, it is not just an ad libitum, because that's one of the things we do. We just open, 500 ml of dextrosaline and we put it in the bowl. And the animal goes there and finish all the 500 ml at once. Then the next thing you're going to see is the animal vomiting. So you are wondering what is happening. When you are administering food orally, the volume have to be timed. The volume have to be determined, and it has to be given in graded doses over a long period of time. This is quite helpful at home, especially when you know that you don't have the capacity to admit the patient. That is where majority of the young ones fall into. They don't have the capacity to admit the patient. They don't have the capacity to monitor the animal over 24 hours that we are talking about, like pet care, like truth mass, that have 24-hour service. In that case, you don't need to stop feed. Just allow the owner to take the dog home and give them instruction as to what to do. When it is 8 p.m., give 50 ml of this. By 10 p.m., the client can do that for you. And that also applies to subcutaneous administration. They are things that the clients can help us to do as a follow-up to what we have administered in our clinic. When you know you don't have the capacity, instead of giving a 1,500 that you are supposed to give over 24 hours, and then you put it in 2 hours, and you ask the owner to take the dog home. And as a result of that, you now cause overhydration. Thank you very much.
Thank you so much, Prof. That was apt. So let's get Dr. Tessie, Dr. Teresa, respond to her own question. Yes, Dr. Teresa.
Hello, Dr.
All right, fantastic. We can hear you now. Go ahead, madam. Dr. Teresa. So I think she's still.
Can you hear me now?
Okay, fantastic.
Can you hear me?
Go ahead.
Okay, I said when you're considering geriatrics, Those are the older patients. We want to, and then you're assessing the dehydration percentage. You want to put into cognizance they would have lost a lot of skin sugar. And then you don't assess them at the same rate as you would a younger animal that has adequate adipose tissue. So you see a lot of elasticity there. Don't just assume, oh, this is and practice. You need to watch out for that so that you don't just see in a geriatric patient a lot of skin folds and all of that. And then you say, okay, it's lost so much fluid. So we have to be guided so that we don't create fluid overload. So that's what I think you should consider in both the pediatrics and in the geriatric patients in determining the maintenance volume. Thank you.
All right, thank you so much, Dr. Tessie. Dr. Judy just said, in addition to what Professor Jadi said about not rushing fluid, this is where referrals come in. There's nothing bad in referring the case to a better equipped facility for the night and pick up the next morning. And I think this referral thing is a culture we need to adopt. The fear among us that somebody will pick up your client should be totally off. I think promoting a culture that does the right thing, regardless of what's happening, whether somebody will take your client or not, will leave the profession better. Let me lastly give a moment to Dr. Anizo, and then I will call the hub experts to make comments on the case presented and then give their final word. Dr. Anizo.
Yeah, thank you very much. Please confirm you can hear me.
Yes, we can hear you.
Okay, thank you to our brilliant presenters. On this, my comment is on this referral issue. I think it's important that we understand the place of the person who is just starting and the fears that inhabit the person's mind and psyche. It's not a bad idea if somebody refers a case to you. I do that. If somebody refers a case to you, you find a way to give him some compensation, give him or her. I mean, a little whatever doesn't go a long way. And then let's also, those of us who are older, let's also make sure that the fears that we take their clients don't materialize. And so when he refers the case to you and you are done with it and the client comes back to you later, you send him back to where he came from. Because some of these fears are not unfounded. One of the labs I use for image, the lab I use in Port Harcourt for image, I think they do that for other vets. I never asked them for any compensation. But I noticed that one day they asked for my account details, and every single time we send the case there to do imaging, they pay us some money. Not much, but it tells you a story about their culture. And I think that's something that vets also need to learn to some extent. You need to encourage them to refer. We can't keep saying refer. And they do that, they lose their client, they lose their money, and you think they continue, they won't. It's a balance that we have to find somewhere. It's an individual thing, you can't legislate it. But I think we need to be encouraged that when they do this, when they send these cases, find a way to compensate them. It doesn't even have to be $1 million or something. Thank you very much.
Thank you so much, Dr. Anizo. One good turn deserves another. So if we're encouraging referrals, once you know that you cannot handle a case, call a colleague to join you. Refer to somebody who is better equipped. We need to keep, what we do here under this Tecla is to cross-pollinate ideas so that we can improve the entire body of knowledge that we have in the veterinary profession, but more importantly, also improve the image of our practice. So while we do that, the idea of also ensuring that the person who is referring to you has this confidence that I'm doing it in a safe environment, it's also very essential. I want to give Professor Ajadi like 2 minutes. Haven't heard everything. What will be the most important take-home points you want everybody? We had over 230 participation of all vets, and that's one of the things we're very proud of. So it's a safe environment of colleagues. What would be the 2-3 important things you want everybody to leave on with? After that, I will go to Dr. Tessie, and then we will start winding up this very engaging meeting.
Yeah, thank you very much, sir. Well, the first thing I want to mention is evaluation. It's very key. That's the background for the success. So you have to evaluate and evaluate and evaluate. The second one is monitoring. It's not just once you finish the first evaluation, that is the end. Then you continue to do the same thing. No, every day you have to keep on monitoring. You have to keep, and based on what you find out from your monitoring, you may have to change one thing or the other. So monitoring is very important. And probably the last one is the personnel. You need the right personnel if you're going to get the result. Yes, you need the right personnel if you're going to get, they must be properly trained, they must be properly remunerated, and they must be properly informed. Thank you very much, sir.
Oh, fantastic. Prof said evaluation. There's a science behind fluid therapy. You must know what you're doing before you start it up. He mentioned monitoring. So you can be handling 10 dogs and collecting money after you have told them it's 50-50 and most of them are dying for your own inadequacies. That will not be fair to the people who we are demanding to be our clients. And then he mentioned your personnel, capacity building. So sometimes I tell my team, it's better to prepare before an opportunity comes. Improving your team's capacity to manage some of these things is one of the important things you could do. That it's so apt and straight to the point. Thank you so much, Prof. Now, Dr. Teresa, if there are 2 or 3 things you need to say, there are over 230 people, veterinarians, who joined this call today, and they all want to. You didn't get the time to tell us how you build. But again, if you want to add that to your final comment, I think we will be glad to hear that.
Yes, thank you, Dr. Kayode. So in conclusion, can you hear me?
Yes, loud and clear. Loud and clear, go ahead, madam.
Awesome. So in conclusion, as to be able to build properly, the practice standard must be worked upon. You do not set up a practice in which you're not thorough and you're not able to impress on your clients and you expect to build them properly. If a client comes in and they are able to be confident in your abilities by 1, the outlook, the general outlook of your practice, you as a person, and then you want them to be able to believe in your competency. And this fluid therapy topic we have taken today is one of the core competencies, like Dr. Ghanaian mentioned, that we have to imbibe it. One of the greatest challenges we have when we have to administer fluid continuously in like the case presented today, the canine virus patient, you need to continue this, become difficult. So can you hear me?
Yes, you were breaking at some point, but I think you're back off now.
Good. So in summary, what I'm saying is, in order for you to be able to build optimally, you have to present yourself, your personnel, to the client that brings in the patient to you optimally. And I said one of the core competencies of a veterinary doctor is to have the skill, acquire the skill to be able to administer the fluid therapy. And when we're talking of continuous IV fluid administration, in like a case that was discussed earlier by Dr. Abiodun, I'm saying we have the challenge that after hours or the next day you've used both limbs, you're going to get short of, okay, other venous accesses. So rather than keep on going in and with your butterfly needle, I'm saying the cannula, we should try to learn and acquire that skill of maintaining continuous fluid access, venous access with your cannula. It's not so difficult to do with 1 or 2 trials. You have that in place. You apply Elizabetha collar on your patient. You monitor your patient while on the table in order not to mutilate it. and then you have continuous access. You administer your IV drugs through that same route, and then you don't need to poke at the patient. So that's it. That's what I have to say in addition. Thank you.
Fantastic, fantastic. So let me get finally Dr. Abiodun. On a lighter note, can you come up, Dr. Abiodun? So your patient survived. How much did you charge? Or
I would have to check. I can't remember right now. I would have to check.
Give us an average. How much do you charge for patients that recover? Like in this case, an average, how much do you charge?
For canine parvovirus or
yes,
or
for,
just
yes, for parvovirus, how much do you charge for that?
well, there are many factors to be put in place.
An average, just give us an average, a quick average.
Well, let's say maybe about 100, 150.
You charge 100,000. Doc, you are on your way to being successful. And I say that on a lighter note anyway. But congratulations and thank you so much. Let me use this medium to thank Prof for sparing his time to educate us on fluid therapy. The recordings of the entire lecture will be out and will be sent to our mail. Let me also take this moment also to thank Dr. Teresa, popularly known as Tessie Beth, for coming to share the calculations with us and your success story around how you've been able to retain your client. Dr. Tumsia will be reaching out to you to see how we can get those calculations and send to the over 400 people who have registered for today's event. And then, of course, to Dr. Abiodun, you are already on your way to being a very successful vet, and we cannot but just wish you the very best. Thank you for the well thought out case study that you have presented. If you don't mind, Dr. Bola, can you just quickly share your screen while we take the post quiz? Don't go, don't go. We need to be sure that you have heard Professor Ajadi's class and you have learned from it. So if you don't mind, Dr. Bolanle, share your screen. Let's take the post quiz. I'm going to be sharing the post quiz now. All right, no, just a moment. Post quiz. So it's still going to be the same question, but we assume that this time around you have listened intently to Professor Ajadi's class, and then we should have 100% success rate in this, or at least close to 90 for people who attended the meeting late. The polls has been launched, and then of course be my guest for the next 3 to 4 minutes while we attempt to solve the question. Let's see. Nobody has answered. We still have about 170 people on the call. We got to over 230 at a particular point in time. So, but again, 170 is still good. We expect that you could quickly just take a moment and help us answer the questions 1 to 10. And then, of course, we will now invite Professor Jadi to give us the correct answer. Then we will be scoring everyone. So one person has finished. We expect more people. We need to take this down to 50%. Then we can call it a day. So please, if you don't mind, you can see the polls. Kindly help us handle. Dr. Ezekiel Jatal said he charges an average of 25 for parvovirus enteritis treatment in Kaduna. Lagos is high. Most of the city centers are higher than some of the suburbs that we have. But again, it's been an interesting class. 4 persons have answered, just 3%. We need to get it up to 50. So the percentage of fluid in the intracellular compartment is, we need you to quickly help us answer that. Which of the following is not a colloid? We need you to quickly help us answer that. Which of the following is not a colloid? Which of the following is not a colloid? The same question, but different options. Which of the following is not a replacement fluid? you agree with me, they looks like jam questions if you're not a vet. But if you're a practicing vet, there should be an easy answer for you. So we have 13%, 22 persons have submitted. We need to get this down up to 50%, then we'll call it a day. We still have well over 170 participants. Oh, I've been corrected. That question 3 is which of the following is not a colloid? The same thing. Okay. Okay, so Dr. Tumsia, I guess you should be preparing to come up and clear yourself. Dr. Tumsia, I think we should make Dr. Tumsia a co-host so that she can help us. 25% have answered. 45 people have submitted their answers. Thank you, Dr. Comfort Temidayo. She said she's done. Thank you. Almost 50 persons have submitted their answers. So we are at 30%. We need to drive this down up to 50%. Thank you, Dr. David. Thank you, Dr. Amaka. You said you're done. Thank you so much for answering. If I have my way, I will attach your name to the answers so that I can also give you your scores on the spot. Thank you, Dr. Omoba Jesu. You said you're done. Thank you. Thank you, Dr. Ayo Wale. Thank you, Dr. Maruf. Adedeji. Thank you, Dr. Ezekiel Jato. Thank you, Dr. Chigoze. Thank you, Dr. Yemisi Adeyemi. Thank you, Dr. Chinyere Obi. Okay, I think I have a better grasp of the answers now. You're done. Thank you. That's the essence of the session. And one of the reasons, Dr. Wakawa Joshua, thank you. One of the reasons why we do the pre-quiz and the post-quiz is to gain knowledge. And thank you for saying that you have a better grasp of the answers now. So we have about 45% submitted their responses, 75 participants to be specific. We need to drive this up to 50. Then I hand over the mic to Dr. Tumsia to take us through the closing formalities. So we have 46, 77% have submitted their responses. We need more. Drive it up to 50. Then we will be done. Dr. Chioma Obwad, thank you. Dr. Ifara Jimmy Raphael, thank you. Dr. Ruben Tauhen, thank you for concluding the survey. We have 47 now. We still have almost 170 participants. 80 persons have submitted their answers. We just need a few more. We have 48 who have submitted. So we have 81 have submitted. Dr. Adama, thank you so much. Dr. Nyeka, thank you so much. Dr. Tumse, are you ready to take over? Say hi so that I know you are set. All right, fantastic.
Yeah, good afternoon, sir.
Oh, over to you. So I think we have 52% submission rate. If you want to end the poll now, it's over to you. Thank you, everybody, for giving me an opportunity to moderate this session. Dr. Tumse.
Yeah, good afternoon, everyone. And I'm sure you all missed me. I was supposed to facilitate the session, but the network didn't permit me to. But I'm glad I'll be able to take us through the end. Thank you all so much for joining in. It was really a refreshing one, though I was in and out. But a very big thank you to Professor Ajadi, Dr. Tessie, and of course, Dr. Abiodun. And I would want to wish Dr. Abiodun a happy 1-year anniversary. I think he clocked 1 year post DVM today. Congrats, Doc. And to everyone for joining in. I'm pretty sure this was a refresher for all of us. And let's kindly adhere to all of the recommendations given by our hub experts and other authorities in the room. So we've taken the post quiz, and I think what next is, can we have the screen up? We're supposed to have our announcements. Have we, sorry, I joined it late, Dr. Femi, have we taken?
Okay, I think we should take
Have we
the
taken
answers.
our final words? Have we taken the final words from our hub experts?
Yes, we have. So I think we need to just take the answers to the questions post quiz.
Okay. Okay, so can we share the results?
Okay, it's been shared now. Can you see it on your screen?
No, I can't.
Can you see it now?
Yes, I can.
Right, good.
Okay, so the first question goes the percentage of fluid, and Professor Ajadi will be answering the questions. He gave the didactic presentation, and we will be answering the questions over under his supervision. So the percentage of fluid in the intracellular compartment is 40%, 90%, 65%, 35%. Over to you, Prof.
65%.
Impressive. 64% of the participants got the answer right. The second question says, which of the following is not a colloid? Dextran, albumin, hemocele, and blood.
The correct answer is blood. Blood is blood. It's not a colloid.
Exactly. 57% got it right. So I think the third question was supposed to be, which of the following is not a crystalloid?
No, not a colloid, or is a crystalloid. I think the question is correct the way it is.
Okay, which of the following is not a colloid? Okay,
Okay.
dextran, hemocele, heterstarch, and Ringer's lactate.
Yeah, the correct answer is Ringer's lactate. Ringer's lactate.
Impressive. 67% got it right. And the fourth question goes, which of the following is not a replacement fluid? Normal saline, 0.5% normal saline, dextrose saline, plasmalite A.
The correct answer is normal saline. Normal saline is a maintenance fluid, not a replacement fluid.
Wow, okay. So just 1% got it right. The fifth question goes, which of the following is not a route for fluid administration? Intravenous, oral, intraperitoneal, and intrasynovial.
The correct answer is intrasynovial.
Okay, 93% got it right. That's highly impressive. And the sixth question says, which of the following is not an important comorbidity to consider when planning fluid administration? Congestive heart failure, renal disease, pulmonary edema, allergic dermatitis.
Yes, allergic dermatitis got it right.
Yes, 96% got it right. That means lots of knowledge has been gained, clearly. The seventh question says, which of the following is an example of fluid disturbance associated with change in content? Hypovolemia, hyperkalemia, hypovolemia, none of the above.
The correct answer is hyperkalemia.
Hyperkalemia, so 42% got it correct. And number 8 says the best equipment for intravenous fluid administration is needle, scalp vein needle, catheter, all of the above.
Yeah, the correct answer is catheter.
Okay, 65% got it right. And the 9th question says the major extracellular anion is chloride, bicarbonate, sulfate, phosphate.
Yeah, the correct answer is chloride.
Excellent, 60% got it right. And the last question is the major intracellular cation is potassium, sodium, calcium, and magnesium.
Potassium got it right.
Sir?
Potassium got it right.
Exactly, 60% got it right. So we can stop sharing. We can stop sharing the results now. At least we can score ourselves individually. And as we said, these answers are based on anonymity. It's just to help us gauge knowledge. If you remember at the beginning, we talked about continuous monitoring of session outcomes. So this is one of the two we use to do that. Next slide, please. So thank you so much for engaging, Prof. Thank you. We'll just take final announcements and we call it a day. So we now serve as a private CE provider for the Veterinary Council of Nigeria. This sessions, next slide, these sessions are free. However, a token of 2,750 is needed to have your VCN accredited and name submitted for CE points. You'd make payments into the following account, Farmalat Echo 79010492235, Providence Bank. Using your VCN number in the description, so you can 38634477.
So I think she got disrupted. I could just pick up from there. So if you're interested in the certificate, I think you could just do well by sending in your payment. Your data will be captured and your evidence to Dr. Tumsia. Can we get to the next slide? All right, so of course, we are providing wholesale service for veterinarians across the country. We are servicing more than 200 animal health stores in Abuja, in Kaduna, in Ibadan, and of course in Lagos. We will soon be opening that of Ibadan. So for anywhere you see Farmalat Distribution Center, I think it would be a nice thing. You hop in and participate in what we're offering. Farmalat Media and Technology, it's also another arm. So your live streaming events, we can cover video and jingle production. We can also cover if you call the number on your screen. Next slide. So we're also supporting the Police Veterinary Hospital in Abuja. And so we have various tests, a well-standard laboratory apartment there, where we do vaginal cytology, hematology analysis, ultrasound, fetal analysis, and the likes. We are also training, using the police personnel to train dogs on obedience, agility, and aggression, just in case you have a client who might be interested in that services. Next slide. All right, so for whatever topic will you want to, okay, so I see somebody asking, please, the link for payment to our emails, we'll be doing that. What other topics do you think it would be nice we cover in our Tecla session? We try and hold our Tecla session twice every month. So if you have a particular topic you think we need to consider and we're not yet talking about, it would be nice for you to state it in our chat box. And a few of us at the back end will be picking up those topics. Next slide. So follow up on all our social media handles, YouTube, LinkedIn, Facebook, and then Instagram, so that you can keep abreast of almost all our activity as it pertains the offerings that we have for the veterinary community. Next slide. It gives me really, really very great pleasure at this point to tell you, so thank you for coming. Thank you for sparing your 2 hours to walk with us through what we call the fluid management therapy. And want to also again and again thank Professor Ajadi, thank Dr. Teresa, and then Dr. Abiodun for being the hub experts that we could look up to. And for everybody who joined, Dr. Gani, Dr. Tunji, Dr. Shegun from Canada, and all the senior colleagues that we have here, who has in one way or the other added to the quality of the programs that we have. So we see all the suggestions. We are going to be picking it up. And then, of course, that will form the curriculum, part of the curriculum we will be considering next. Please do have a wonderful afternoon and vote wisely. We'll be going to the polls on Saturday, and it's a great pleasure to see that we encourage every one of you to vote and be a civil part of the progress Nigeria is about to make. Thank you and have a wonderful afternoon. Everybody will now be unmuted, so you could unmute yourself and say what